I have a clock that's counting me down. But I think I'm going to need more time than is on this clock. So hopefully nothing happens when we get down to 0.
As someone who's in a lot of e-learning in my master's program, it just counts down to 0 and then nothing happens.
Okay, thanks. Otherwise, I'm going to have to talk really fast. Okay, so I think I'll get started. I think probably everyone's here who's going to be here. All right, let me just move this so I can see my slides. Everybody can see my slides, yes? All right, so I'm so happy to be talking to you guys about mental health and IBD, and I'm actually just looking at, we don't have a huge group here, so you're welcome if you want your questions to be anonymous, you're welcome to throw those into the chat format, but if I'm talking about something and you want to jump in, like please feel free to just jump in and ask a question. If we end up like really getting slowed down, then maybe we'll change that as we go through, but I'm happy to kind of have this be like an open conversation. So, okay, I do not have any disclosures for today's talk, but what I wanted to start out with was just a brief history of IBD in psychology. This is something that I actually only learned about recently, and I thought that it was so fascinating. So in the 1930s, IBD was considered a psychosomatic condition. And psychosomatic is defined as a physical illness or condition that's really caused by a mental factor, such as internal conflict or stress. And so when we hear people talking about psychosomatic conditions, it's really things like, stress headaches or, physical symptoms that come up because of, mental health reasons. And of course, we know that that's not true about IBD. But what's really interesting in terms of like the history of, the role of psychology and IBD is that after this, there was a real backlash where any connection between stress and IBD was disregarded. And I think it was because that like considering IBD psychosomatic was so stigmatizing that in order to try to protect you all and kind of get the right information, the medical community said that stress has no role in IBD, it's only a medical condition. And so luckily, we've come kind of back to like a nice middle ground since that point, where now we really view mental health as an important component of the IBD experience, as something that we need to kind of consider and tap into in terms of high quality care for IBD, but not the main cause of IBD and not having nothing to do with it at all. So GI psychology, which is my specialty, I just wanted to give you a quick introduction to it because a lot of people have not heard of GI psychology. So we are psychologists and social workers who are trained beyond traditional psychotherapy. And we're trained to work with patients with chronic GI conditions, to work in medical settings and as part of a medical team, and to deliver interventions targeted at improving health and coping with illness. And so over the last several decades, this has been a growing field. It looks like it's going to continue to grow. I would like to see it that there's a psychologist available in most gastroenterology practices, because I think it really is such an important part just of general, care, especially for patients with IBD, but also other conditions like irritable bowel syndrome. I'll be talking a little bit about that today. And so, I think more and more the role of psychology and approaching mental health concerns is really, understood and valued in terms of caring for patients with digestive conditions. And so GI psychology applies specifically to IBD. I think in these 5 areas is kind of where I see it coming up mostly in my practice. So coping with chronic illness, this is a huge area that could have, there's a lot more that goes into that. Maximizing quality of life living with chronic illness. Addressing anxiety and depression related to a new diagnosis or ongoing symptoms, or even different disease management and treatment recommendations. Addressing stigma that can often come with having any chronic illness, but especially a digestive one, and considering the brain-gut axis and the role of the brain-gut axis in symptom experience. And I'll be talking about each of these a little bit more today. So I use this slide in almost every mental health and IBD presentation that I give, because when we're thinking about caring for a patient with IBD, we're really, my goal would be for us to not only be focusing on the bowels, right? There's so much more, that having IBD affects. It's not just your bowels. So we're thinking about self-esteem, maybe feeling different from others, especially for those patients who were diagnosed early on, kind of like how did that kind of play into your, evolving self-identity. Emotional functioning or worries about symptoms, worries about the future, quality of life, fear that symptoms might, impact your choice of activities, or maybe there's something that you really would like to do, but you're not sure if you can do it because of your diagnosis. Social functioning, so how do you talk to others about IBD? Do you talk to others about IBD? I'm going to skip over to family dynamics. So, how does this kind of interact with your family? Are your family members very worried? Do they have all the information that they need to help to support you? And then physical well-being. So physical well-being, we, really turn that over to your medical team. Your physicians have studied for many years and they have expertise in how to treat your IBD. But GI psychology can really, jump in here too, in terms of teaching relaxation training, helping patients to increase physical activity or improve physical health in general. And of course, addressing barriers to treatment adherence. So, if the physicians really have recommended a treatment that they think would be really good for you, but there are things that are keeping you from really, following their recommendations, kind of having a chance to talk that through and say, what's going on here and how can we help you to kind of be healthy and follow their recommendations. And so, I also want to just throw this here, because when we talk about mental health, and I'm guilty of this too, but so often the term mental health becomes synonymous with like anxiety and depression and things that maybe aren't feeling good or aren't going well. But really within mental health, we also have really positive things. So people who are coping well, people who are resilient in the face of, adversity, people who have, good self-esteem. And so when we're thinking about treating patients with chronic conditions, we don't need to wait for anxiety or depression to occur in order for a patient to really benefit from addressing their mental health. So sometimes the role of a health psychologist is to say not only what's gone wrong or what's making you feel bad, but to really take a good look at what's going right and how can we shore that up for you for success in the future. And so I would say, for patients to know and also for providers to know that we don't need to wait for somebody to come into the office crying or saying that they're incredibly worried for, a referral to talk to a GI psychologist or a psychologist who's trained, in physical, health psychology to be helpful or maybe kind of help you along. But that said, there are a lot of patients who have IBD who do have symptoms of depression and anxiety. So I just wanted to go through quickly what to look for. If any of this rings a bell for you, it might be worth having a conversation with your gastroenterologist or primary care doctor, or I'll give you some resources to how to look up psychologists in your area, but it might be worth sitting down and talking to somebody. So depression is generally characterized as having depressed or irritable mood more days than not, and loss of interest in activities that you would otherwise have enjoyed. Depression usually comes with a change in appetite, so sometimes people eat much more than their normal amount, or they have no appetite at all. Change in sleep, so maybe they're sleeping a lot or not sleeping as much. Feelings of worthlessness, hopelessness, and often kind of fatigue or low energy. And anxiety is characterized by excessive worry that's difficult to control. People who are anxious might feel very restless. They may also notice fatigue or sleep problems, be irritable, and kind of report more physical aches and pains. Now, I do want to point out that, so I put an asterisk next to kind of like the core symptoms of each of these, but these other, symptoms that come in terms of change of appetite and fatigue or low energy or feeling restless or irritable, these might also look familiar for those of you who have taken steroids, or, these also might look familiar in terms of just having active disease. And so sometimes it's not easy to kind of tell the difference between, well, could this really be depression or is this a symptom of IBD? And in that case, you should never be diagnosed with depression or anxiety, but sometimes we don't really need to tease those things apart for mental health intervention to still help a bit. So people often ask me if mental health concerns are more common in IBD, and for a long time, the research wasn't really that, the answer was there, but it wasn't that kind of conclusive. But so by now we know that people who have IBD tend to be at an increased risk for both depression and anxiety. So we know that 21% meet criteria for an anxiety disorder, but 35% report symptoms of anxiety without meeting the full criteria for a diagnosable anxiety disorder. 15% meet criteria for depression, and 22% report symptoms of depression. And this is as high as 2 to 3 times more common than the general population. We do know that depression and anxiety are highest in patients with active disease, but patients with inactive disease are still more likely to report anxiety or depression compared to the general population. And there's some research to indicate that Crohn's disease may have higher rates of both depression and anxiety compared to ulcerative colitis. So there was one study of 432 patients with IBD that was done at Pennsylvania State College, and they found that 44% met criteria for depression or anxiety, and 20% had both. That's pretty high. And so within that sample of patients, they wanted to know what factors were associated with depression or anxiety, and they found that people who smoked, people who had more extraintestinal symptoms, so those are symptoms like chronic pain, headaches, things that aren't directly related to your intestines, and history of surgery were more likely to meet criteria for depression or anxiety. And they also found, and I don't think that any of this is surprising, but people with depression or anxiety were also more likely to be hospitalized, visit the ER, have more severe inflammation and endoscopy, but also report more severe symptoms even when inflammation wasn't present. And so I'm going to spend a little bit of time today too talking about when inflammation isn't present and when your doctors are telling you that you're in remission, but you still are having, chronic symptoms, like some of what we know about that. All right, so depression and anxiety, that's one thing, but a lot of people don't feel that they have depression or anxiety. They feel like their mood's pretty well under control. They have worries, but it's not really beyond kind of what you would expect for whatever their situation is. But then the other question comes up about stress. So we all have stress. It's 2020. I don't think anybody here has not been stressed this year, at least a little bit. And so people will also ask me, what's the relationship between stress and IBD? And so there too, the relationship becomes a bit complex, but my first answer is it's a two-way street. So the one way where that's really easy to explain is that symptoms cause stress almost all the time. So if you have a new symptoms that are coming up, or you've been feeling really well and now suddenly you're not feeling so good, it's highly likely that you're going to have an increase in stress in your day-to-day. So people asking themselves things like, am I going to have to miss work? Am I going to flare? Where's the nearest bathroom? Will this ever get better? Am I going to need to change my medications? What about surgery? I mean, just having these thoughts is stressful. The part of this two-way street that's a little bit harder to explain in IBD is whether stress causes symptoms. So we know that stress is not the primary cause of symptoms, but we also know that stress can affect our physical functioning. So it doesn't really help anything, in our bodies at all. There's all sorts of physiologic changes that happen when we're under chronic stress. And so it's something to kind of keep our eye on in terms of, a potential factor that can exacerbate symptoms and that can definitely affect quality of life. Sorry, I just lost. Here we go. So I included this from a publication from 2012 to show that, in IBD, there is research going on about the role of stress in symptom presentation. And there are both direct effects of stress on our bodies and indirect effect of stress on our symptoms. So the indirect effects are when we are chronically stressed, we tend not to take as good care of our body. So we might, people who used to be smokers might be more likely to going back to smoking, or if you're very stressed, you might be more likely to miss a dose of medication, or miss an infusion. If you have a lot going on, hopefully not. I know when I'm stressed, I drink more coffee and I drink less water, right? So even small things like that can change kind of what's going on in our body. But there are also direct effects of stress on our gut, including changes to cytokine profiles and intestinal permeability, and different kind of inflammatory markers. And so, having a stressful day at work, having a stressful week at work probably isn't going to do too much in terms of, measurable changes in your symptoms, but having chronic stress can make all of these changes kind of add up and may actually, influence your experience of IBD symptoms. So this slide kind of just gets at that same thing where, it doesn't actually matter what the stressor is It matters how chronic your stress is and how you perceive that stress. So, some people will say to me, like, I've been really stressed about this one thing for so long, but like, it's actually not that big of a deal. Like, in the scheme of things, people can go through much worse things. And the answer is really, it doesn't matter if it's, objectively a like incredibly severe stressor. What matters is the chronicity of it, and it matters like how it's impacting you. So it doesn't have to be, a traumatic experience or something really major to have an effect on your body. And so, for this, there are definitely, like I just showed you, there are definitely like direct pathways that stress can impact your gut. But the mind-body relationship is important really for any chronic health conditions. And if you can think of a chronic health condition, there's probably been a research study to support the, role of mental health or psychology in treating those conditions. So chronic pain, diabetes, cardiovascular conditions. The thing that gets kind of unique about chronic gastrointestinal conditions is the brain-gut axis. So we have this, specific kind of connection between our brains and our guts that adds this extra, layer to, the relationship between our physical functioning and our mental health. So I'm not sure if any of you have heard of the brain-gut connection. This is something that we talk about a lot when we're thinking about the role of mental health and irritable bowel syndrome. But basically, our brains and our guts are always communicating with each other, even when we're sleeping. So the guts are sending signal to our brains saying, I'm full, I'm hungry, this doesn't feel right, or everything's working okay. And our brains are processing those signals and then responding to them accordingly. And similarly, our brain is talking to our gut. So I'm happy, I'm nervous, we're safe, we're in danger. And this is happening all of the time. And so you can think about this, and if you've ever had the experience of having like a pit in your stomach or butterflies in your stomach, if you were very anxious or apprehensive about something, and that's really a direct illustration of your brain sending its emotional signals to your gut and your gut responding. So in IBS, so irritable bowel syndrome, we consider this actually dysfunction of the brain-gut connection. And so patients who have irritable bowel syndrome, we think that kind of that communication between the brain and the gut has gone just haywire. With IBD, we often see that patients who are in remission and whose doctors are telling them, like, all your tests look normal, your scopes look good, like there's no reason for you to be having these symptoms, that sometimes patients with IBD who are in remission may have this brain-gut connection, like go a little bit haywire. And we think that that can be an explanation sometimes for having chronic digestive symptoms, even when your IBD is under good control. So I'm not going to actually go through that. This basically says the same thing, but it's a really nice infographic from the AGA. They have it, publicly available, I think, but basically to kind of just describe, this relationship between your brain and your gut. And at the end, they suggest specific mental health interventions to target this brain-gut connection. I'll go through some of those in a couple slides. Okay, so I've already showed you this, but now I'm going to get into some of the more practical kind of ways that a mental health provider can help patients with IBD. So first thing, I already explained to you the role of GI psychology and kind of like what we do and how we're trained. But it's also important to know that many times patients who see a GI psychologist also see a general mental health provider. And so that would be psychologists or social workers who are trained in the treatment of common mental health conditions, especially anxiety or depression. And they'll offer short-term or long-term therapies. And so I have patients who will see me where we focus specifically on whatever's going on in terms of IBD, but then they also see their general mental health provider. And that's actually kind of a nice setup, because then I don't have to also, treat the anxiety or depression while we're trying to focus on the IBD. So I wanted to say that it's common for patients to see both. In terms of billing, there are ways to bill that it can be covered to see both. And if you don't have access to a GI psychologist, because unfortunately there's not quite enough of us yet, a general mental health provider can do a lot of what I'm about to describe to you. So first things first, in any psychotherapy, for those of you who have never seen a psychologist, basically what you're doing is you're talking it out. This is kind of like the core of psychotherapy. So just the act of sitting down and talking about our worries and emotions in a setting where you can kind of like bring it there talk about it and then leave, right? And you don't have to deal with somebody calling you throughout the week and saying, hey, how you're feeling? I'm so worried about you, right? Like there's a defined time to go talk about what's going on can be incredibly helpful. So the core of any psychotherapy is to really build understanding about your emotions, build understanding about your behaviors, and to feel heard and understood and kind of have a safe place there. And this happens with any mental health provider. But some of the IBD specific concerns that come up, especially in my practice, and I mentioned some of these earlier, but so of course, coping with the new diagnosis, just kind of like reeling with all the information, figuring out like, how do I organize, my thoughts around this? How do I organize my emotions around this? What are the questions that I need answered? So I think having a therapist that can even sit down with you to write down your questions and even make kind of like a very simple plan of like, these are your questions. The next time you see your doctor, these are the 5 questions that we really need to get answered. If you don't get them all answered, then like we'll come back to those too, right? But it can be helpful just to kind of like get organized. But food avoidance and food restriction, these are some things that can also come up in my practice where, we know that a large percentage of patients with IBD will self-prescribe dietary restrictions. There's really nothing wrong with that, especially if they find that it helps, but sometimes that can reach a point where, a couple of years ago, somebody went gluten-free and now they're adding on another restriction, and very gradually we can get to a point where there's actually a very limited amount of food or a different variety of food that patients are able or willing to eat. And so really kind of taking a look at that, like, can we broaden this for your quality of life and also for your health? A mental health provider might help work with insomnia or fatigue. So we know that there's high rates of insomnia and IBD compared to the general population, even in patients in remission. And so a health psychologist can help to, help promote healthy sleep habits, or even do some like specific interventions for insomnia. Thinking about lifestyle modifications, so tobacco cessation for those patients who are smoking cigarettes or using tobacco, or weight management, both increasing weight and decreasing weight depending on what the doctors are recommending. Evaluating the impact on work and productivity. So especially in patients who are newly diagnosed, because their minds are kind of, like they're trying to sort out all this stuff, but then also trying to fulfill whatever role they, were in right before they got the diagnosis. There are really high rates of what we call presenteeism, where people are still going to work, but just not getting as much done or feeling as productive as they, would have otherwise been. And so even just thinking about like behavioral interventions, recommendations to help people to feel like they're being productive at work. And of course, worrying about the disease course. So having a chance to talk out, like, how will things go in the future, and what are some strategies to help to stay comfortable while we don't know what the future will bring. So kind of finding comfort in that uncertainty. Now, this one is something that comes up a lot, so I wanted to talk about it, but I will say that this is probably the only one that I'm going to talk about today that should probably not be done with a general mental health provider, because you kind of start to tiptoe the line of, what we're qualified to do. So I have a lot of patients who are referred to me because they have been, advised that especially like a biologic therapy or surgery would probably be a useful thing to consider, and they are not wanting to consider that thing. And so sometimes patients come to my office because their doctors want them to kind of like really sort out why they don't want to consider this recommendation. And the patients are trying to wrap their mind around whatever the recommendation is. Now, a psychologist should never make a medical recommendation. And so as the patient is making decisions about treatment, the role of the psychologist is really just to be a support and be kind of a sounding board, help patients to get their thoughts kind of organized and together, and help them to, figure out when they should go back and ask their physician a question. So when this comes up for me, this is where it's really important for me to be part of the medical team. But I always discuss it with the physician first. I'll never make a recommendation of my own, but really just help patients to figure out, like, well, what would be the pros and cons be of a biologic therapy? What are you afraid might happen if you start it? What are you afraid might happen if you don't start it? And so like starting to just think through, like, what is the motivation for making or not making this decision, and help the patient to make the right choice for themselves. So intimacy and fertility, these are topics that I bring up a lot in therapy with my patients, only because these are topics that people don't often want to bring up with physicians, and sometimes they're not thinking about wanting to bring it up at all because it feels like such a personal topic. So of course, if somebody doesn't want to talk about it with me, they don't have to, but I like to open the door just to make sure that they know it's a safe place for them to discuss it with me. So thinking about body image and how that might, impact one's kind of interest in being intimate with another. So thinking weight changes, hair loss, surgeries, fistulas, and really processing like how their body image may have changed, as a result of their diagnosis. We know that up to 31% of men and 80% of women with IBD report decreased interest in sex, and that sexual functioning can be impacted in, a pretty significant proportion of our patients. And so, even talking that through, we're talking about like, if a patient's diagnosis has impacted their relationship, if they have a partner, or their willingness to, want to be intimate with others. Another really important statistic that we don't often talk about, and that, it's a hard thing to bring up, I think, in a clinic visit, because clinic visits are like 15 to 20 minutes when you have a follow-up, and, physicians don't always know if somebody wants to talk about this. But we also know that 18% of women with Crohn's and 14% of women with ulcerative colitis report voluntary childlessness, which is a lot higher than in the general population. And there's really no reason for, somebody to choose this because of their, there's no medical reason for somebody to choose this because of their diagnosis. And so I think that this is something that, women of childbearing age especially need to be asked about, and they need to have a safe place to kind of talk about this if they're making this choice because of their condition, and, kind of what that means to them. All right, and stigma came up a bit during our patient panel, but we think about stigma in 3 different ways. So we think about perceived stigma, which is when you hold the sense, or you sense that others hold negative beliefs about you or your condition. We think about enacted stigma, so that's when other people actually treat you differently. It's not just you thinking that they think differently, you're noticing their behavior has changed. And internalized stigma, which is when the patient believes the stigma about themselves and kind of turns that on themselves. And we know that high rates of stigma are associated with poorer disease outcomes, so poorer quality of life, sometimes poorer medication adherence, psychological distress, or low self-esteem. And so I think, having patients like really think about if stigma has been present, like if they have, noticed perceived or inactive stigma, or if they have any internalized stigmas, and then really like working through kind of how to handle those, and for the internalized stigma, how to, reverse those if we can. All right, so I want to talk a little bit about that IBD-IBS overlap, which, like I said, is when the disease is in remission, but symptoms are still pretty bothersome. And so this would be patients who are having recurrent diarrhea, abdominal pain, even though their disease, they're being told that their disease is under good control. And so for those patients, really up until now, the IBD-specific concerns, we're really thinking more about like helping patients to cope with their condition, helping patients to improve their quality of life, helping patients to kind of just sort through like what does it mean for them to have IBD. For the patients who have this IBS overlap, or this like brain-gut dysfunction, then the focus becomes actually more on helping patients to control those symptoms. So when you're having symptoms in the setting of IBD that's in remission, a mental health treatment can actually help you to stop those symptoms or to reduce the severity of those symptoms. And so for that, we're thinking about things like stress management, physical relaxation techniques, or medical hypnosis or cognitive behavioral therapy. And like I said, so for most patients who have IBD, the goal is not to help to improve your symptoms. For patients who have the IBS overlap, the good news is that a mental health intervention actually can help the severity of that symptom to go down. Okay, and now I wanted to end on, well, I'm not done with the talk, but I'm going to shift gears in just a second. But I want to end this portion of it on like kind of a more positive. So we've been talking about a lot of the things that can go wrong. I'm sure none of these things resonated, or not all of these things resonated for one person, but everybody probably had one thing where they were like, oh yeah, like that's something that I've gone through. But at the end, I want to talk about resilience, because resilience is something that's so positively focused. It's based on positive psychology, and it's something that's really up and coming. There's research that's happening in the last year or two and coming out now, describing the role of resilience in patients who have inflammatory bowel disease. So resilience is defined as the inherent and modifiable capacity of an individual to cope or recover from adversity. And in the research that's coming out of New York right now, they found that there's an independent association between patients who have high resilience and between high resilience and lower disease activity. So the more you can build resilience, or you could build this ability to cope and recover from adversity, the better your disease outcomes are, essentially. And so this is basically late breaking. I mean, it came, the results of the study came out last weekend, but it's called the GRIT study, and it's happening at the, I don't know how to say it, the Icahn School of Medicine in Mount Sinai. And it basically is building on principles of positive psychology, focusing on how people flourish even when they're, presented with obstacles. So they build these 6 outcomes, and they help patients to become more optimistic, which my understanding of the optimistic is less kind of expecting positive outcomes and more hoping for positive outcomes. I think it's a subtle difference, but I think it's an important one too. So maybe building hope, building optimism. Working on disease acceptance, self-regulation skills, building self-efficacy, building social support, and then of course building resilience. And so I just think that this is such a nice way to kind of conceptualize the mental health treatment of patients with IBD, because it's really thinking about, instead of taking things that are going wrong, right, which is what all of my previous slides were looking at, taking things that aren't working out so well, it's really saying let's take what's going right and make that go even better for you. And so I think that this is probably where the future of IBD, mental health and IBD is going to go. And I think it's a great direction for things to be heading. Okay, so for my final part of my talk, what I wanted to do was really actually just describe the different kinds of treatments that are available for patients with chronic digestive conditions. So in IBD, there's been some research about cognitive behavioral therapy and medical hypnosis. There's also been research about mindfulness and disease self-management training. But if you were to see a health psychologist, you're probably most likely to be offered either cognitive behavioral therapy or medical hypnosis. So I wanted to just give you a quick introduction to what those two kind of theoretical backgrounds are and what we know about them in IBD. Like I said, mostly for CBT, we're thinking about reducing anxiety or depression, improving coping, or addressing quality of life. With medical hypnosis, there's actually a little bit of data to suggest that it can intervene on inflammatory markers or actually improve some of the physical functioning. But most of the time, unless we're treating a comorbid irritable bowel syndrome, we're really thinking about improving quality of life and kind of just improving coping, with your condition. So, okay, so this is just a quick introduction to kind of the theory of cognitive behavioral therapy. So CBT was initially developed as a treatment for depression in the 1960s by Dr. Aaron Beck. It's been applied to a wide range of mental health and chronic medical conditions, and not necessarily being used specifically for depression or anxiety anymore, but pretty much if there's something in your life that's causing stress, CBT can be applied to it. And it refers to a theoretical orientation and not necessarily a predefined set of techniques. So at the core of cognitive behavioral therapy, we're thinking about how thoughts, behaviors, and emotions are all related to each other. So how we think affects how we feel emotionally and how we behave. How we behave affects how we think and how we feel. And how we feel affects how we think and how we behave. And so I'm going to show you a little bit more about this. I've put a star next to the thoughts and the behaviors. Oops. Because I can't intervene on somebody's emotional functioning, right? So if somebody comes up and tells me, I'm feeling sad, I'm feeling anxious, I can't say, don't feel sad or don't feel anxious. If that worked, I wouldn't need a job. It would be as simple as that. This really wouldn't be a problem. So if somebody's feeling sad or anxious, what we can do is we could say, okay, what are the thoughts or what are the behaviors that are promoting, that negative emotion? And can we change those thoughts or change those behaviors in order to help you to feel better? So to illustrate this a little bit further, I'm going to kind of give you some of the background about what we know about thoughts in cognitive behavioral theory. So many people think that we have an event happen to us, or we're in a specific situation. So we're stuck in traffic and we feel frustrated, angry, annoyed, right? And this kind of seems obvious that like something happens to us and we have an emotion. In cognitive behavioral theory, we actually say we have the event, and then there's a thought or a belief. I can't take this commute any longer. I'm going to lose my job if I'm late again. This is horrible. I can't believe this is happening. And as a result of that thought or belief, we have this reaction. And so that thought or belief sometimes is very obvious to us. Sometimes we really know we're thinking it. Other times it's kind of running more in the background, where it's like we're just perceiving the event in a specific light, and those thoughts or beliefs are kind of happening without us being as aware of it. But what we know is that if we can identify what your thoughts and beliefs are in a specific situation, we can help you to think a thought that's maybe more rational or more helpful, right? So maybe somebody else in this traffic jam is thinking, this traffic is really stressful, but there's nothing I can do about it. I'm going to call work and let them know. And in the meantime, I'll try enjoying listening to this book on tape. That
Hello. Were any of you still in the middle of your breakout room and got kicked out? Yeah. Okay.
Yeah,
Let me send you right back. All right.
We're back, Sarah.
We're back. Okay, hi. Let me share my screen again. Okay, so we were talking about how thoughts and beliefs can affect our emotional reaction, right? And so I always use the example of being stuck in traffic because everybody can relate to that, right? And when we're thinking about changing our thoughts or beliefs, we're not thinking about changing those thoughts or beliefs to be like, oh, I'm so happy that this is happening to me, or like, this is the greatest thing that could have happened all day, right? Like, we want the thoughts or beliefs to still be very true for you, but not to be something that where you're, telling yourself, I'm going to lose my job, right? Because that doesn't help you get through the traffic any faster, but it really does help you to feel a lot worse than like, okay, I called in and I'm going to deal with it when I get there. So I just threw this slide in here to say that Dr. Beck did not invent this idea that thoughts or beliefs are really what is kind of like influencing the relationship between our situations and our emotions. So this idea that men are disturbed not by things, but by the views which they take of them by Epictetus was long time ago. In Shakespeare, there's nothing good or bad, but thinking makes it so. So this notion that like how we think about what's going on or how we think about our circumstances is influencing how we feel about them has been around for a long time, but Dr. Beck just turned it into a therapy. And so to kind of tie it all up then, so we know that we have situations, we have thoughts about our situations, we have emotions about those, about what's going on or in our environment. We have behaviors relating back to our emotions and our thoughts, and we have physical sensations. And so in cognitive behavioral therapy, really what we're doing is anytime you have something happen in your life that like elicits an emotion, we say, let's break it down into these 5 factors. So you're stuck in traffic, you think I can't be late, you feel anxious or worried. Maybe your behaviors are you're gripping the steering wheel, you're honking the horn, and you have muscle tension and heart racing, right? In CBT, really, you're just learning to identify patterns of thinking and behaving and feeling. We're going to reframe the unhelpful thoughts. We'll replace the unhelpful behaviors, and we'll practice physical relaxation to help to make all of these 5 factors kind of just feel a bit more comfortable. So this is a IBS specific example that I usually use, but the situation would be you're invited to dinner with coworkers. I might have to leave early. What if I need to rush to the bathroom? You feel nervous and anxious. You might decline the invitation because it's just not worth taking the risk that you would have to leave early or draw attention to the fact that you're in the bathroom for a long time. Maybe you go and you only eat dinner or eat bread at dinner, or maybe all day long you monitor closely for signs of symptoms and you make a decision at the last minute. The physical sensations there might be having a racing heart or feeling an increase in abdominal pain, especially just because now you're kind of like honed in on how does your stomach feel. And so in cognitive behavioral therapy, we really say like, are these thoughts and behaviors especially, are they helpful to you? And if they're not helpful, is there something else we can replace them with something that would feel a little bit more helpful or not result in emotions that are quite as intense? Okay, and so I'm going to end today talking just about medical hypnosis because this is something that it has been tested in inflammatory bowel disease. The results are incredibly compelling and I think really interesting. The studies have been small, so we need more studies, of course, and I don't want to kind of get everybody too excited about it, except that there's also very little to lose by trying it if you have access to somebody who's trained in medical hypnosis. So medical hypnosis is an evidence-based therapy, and it's not the same as stage hypnosis. So it's not the like cluck like a chicken and like lose control over kind of like your own body, right? With medical hypnosis, the patients are very much still in control. The doctor's not making you do anything that you don't want to do. But it really is kind of an idea of getting into a really deeply relaxed state and then being more open to suggestions of healing and well-being. So medical hypnosis has been tested in cancer, in arthritis, HIV, fibromyalgia, chronic pain. I should have put irritable bowel syndrome in here too, because it's shown to be highly effective in IBS, and the studies are larger, and there have been more of them in IBS. But in terms of IBD, it suggests that hypnotherapy can have positive effects on immune parameters and like inflammatory markers. And hypnosis in inpatient settings, so not necessarily for IBD, but has been shown to decrease the length of hospital stays, decrease pain medication use, and actually increase wound healing after surgery. So that can all probably be applied to IBD. So this is what the studies in IBD have shown us specifically. So there's one study that did one single session of hypnotherapy in patients with ulcerative colitis, and they found basically reduced inflammatory markers after just a single session in ulcerative colitis. Another study looked at 7 sessions of hypnotherapy, also in ulcerative colitis, and they showed that it improved quality of life, reduced symptom burden, and probably most important, prolonged clinical remission in those patients. I think they followed them for a year. And then in other chronic GI conditions, like I said, it's been shown to be highly effective in reducing symptoms and improving quality of life. So in IBS, for example, I think when they've compiled all of the data from different trials, they found that 70% of patients reported at least a 50% reduction in symptoms. So pretty good for something that doesn't really have any side effects. And so when we think about hypnotherapy in terms of the brain-gut axis, we're really thinking about hypnotherapy as something that can kind of turn down the volume in that interaction between the brain and the gut. And so, for the patients who are having symptoms that are like irritable bowel syndrome, if those signals from the gut to the brain and the brain to the gut are a little bit exaggerated, or if the intensity of them is just too strong and that's causing symptoms, we would think of hypnotherapy as just one way to turn down the volume of those. And I usually add some slide like this whenever I'm talking about hypnotherapy, because I know it kind of sounds like this like strange magical intervention, and we don't know exactly how it works, but we do know from brain imaging studies that there are measurable changes in brain functioning, especially in the anterior cingulate cortex, which is an area of the brain that processes pain and processes emotions. And so something really is happening with hypnotherapy where the brain is kind of modulating those pain signals and maybe like modulating how emotions are being sent to the gut in a measurable way. And so, the science, of brain imaging is still kind of like, it can't answer all of our questions yet, but I think especially for something like hypnotherapy that can sound a bit crunchy to people, it's nice to know that there's, measurable changes that we can see in brain imaging. Okay, and so if you don't have access to a GI psychologist, and probably most of you don't, unfortunately, but I hope that will change in the next couple of years, what can you do? So the first thing I would do is I would try to find a psychologist that's trained in health psychology, and this should not be that difficult. There are a lot of people trained in health psychology. The first place that I start, like if I'm trying to help a patient find somebody, other than me is psychologytoday.com. So you can filter by health insurance coverage. You can filter by, what you're looking for. So, maybe you go in there and you can just put in like chronic pain or chronic illness. And somebody who's trained in treating patients with chronic pain probably will have like enough of health psychology training that they would be able to learn about IBD enough to help you out. You can filter, of course, by location. So they're all different filters. So it's a great resource, and I would try to find somebody trained in health psychology. But for those of you who don't want or need to see a psychologist right now, it doesn't mean that you can't kind of achieve therapeutic benefits. So therapy can happen in many settings outside of clinic. And this might be just as simple as like intentionally making time to be with friends and family or people you enjoy, carving out time for yourselves, engaging in hobbies or things that bring you joy, journaling, or thinking about how some of the following topics impact you. So have you stopped doing things that you used to enjoy, and why? And if you have, could you start them again? Or what are the barriers? Are there modifications that you can make so that you could enjoy them again? Do you hold beliefs about what it means to have IBD? Are those beliefs positive or negative or both? In what ways are you managing well? And are there things that you could improve upon? I always recommend that patients start a meditation practice. You don't have to do it every day, and you don't have to do it for hours at a time, but even 10 minutes of meditation or deep breathing a day can be really helpful. And yoga or, just regular exercise, especially for those of us who are working from home these days. I find, now more than ever, it's easy to just sit down at your desk and just like not stand up. When you're at an office, you might walk and get a coffee or stop by a coworker's, desk. And, a lot of people aren't doing that now. So I would say really trying to build in like some physical movement, when you can, going for a walk if the weather permits, or doing yoga or something like that at home. Okay. And then different meditations and relaxation apps that I like. So Headspace and Calm, I think, are my two favorite, but they're also paid subscriptions, and they're not cheap. I mean, I think they're like maybe $12 to $15 a month. The reason that I like them is because they're like curated really nicely. So if you have if you want to work on anxiety, or you want to work on stress, or they have really specific programs. Like you click on that program and then there's no decisions you have to make other than to listen to the meditation. Insight Timer is also really good, and this one's free, but I would liken this to like the Netflix of meditation. So if you don't know what you want, you could spend 20 minutes like browsing through meditations and then just decide not to meditate at all. So I think Insight Timer has a really good option. I love that it's free, but I would say like pop on, give yourself 5 minutes to pick one, and then just do whichever one you pick instead of kind of getting stuck to try to find the perfect one. Okay, so I want to leave time for questions. So I'm going to wrap up here. I'm going to stop sharing. And I'll take questions. So I don't see any questions in the chat, but let's see, I don't know if we've grown. No, we still have kind of a small group. So if you want to just unmute yourself and ask any questions, if you have them, I'd be happy to answer them.
I have a question.
Mm-hmm.
As a co-facilitator of a Crohn's IBD in-person support group, I've seen a lot of different people over the past 9 or 10 years. And it seems like a fair proportion of people mention prayer or some sort of religious belief as something that they lean on heavily. How important is that? And is that something that essentially is kind of not a substitute, but an alternate path forward, if you're not into new agey stuff, meditation, yoga, I think especially among the somewhat older, well, I guess much older and much younger, I tend to see more religious.
I think that's such a great question. And so I think the answer is if a patient has a religion that they follow and a prayer practice that they use, it can be an incredibly important resource for them, but it's not necessary. So patients who aren't religious don't need that in order to do well. I think where prayer and religion really come in for chronic illness is that there's so much uncertainty about how things will go in the future or what is going to happen. And I think where patients really get stuck is in that uncertainty, and how much energy do they want to give kind of thinking about the different possibilities. And prayer and religion can be really good there and can kind of come in and help patients a lot, because you can almost hand that over to whatever your religion is, or if you believe in God, you can kind of like hand that over to God. And so I found that patients who are able to kind of use prayer in that way can find peace in that uncertainty, sometimes a little bit easier than patients who don't use prayer, although patients who don't use prayer can find that too. Are there any other questions today? Okay. I think that's probably a no. I don't know if we just need to stay online. I mean, if anybody thinks of questions, feel free to chime in. I don't know what happens at noon. I think it's over, right?
I just wanted to say that it was really great and I loved your presentation. It was awesome.
Oh, thank you. Thank you.
I'll let Arushi know that we're finished.
Yeah, no questions because it was very comprehensive. Super well done. Thank you so much.
Oh, no problem. I was thinking of you, Alex, when I was talking about some of the stuff, because I was like, oh, this is probably a review for her, but I think it's always nice to see how other people explain some of these things.
It's awesome. And this is ridiculous, but with COVID and not being able to get enough fieldwork hours, this counts for fieldwork hours. So.
Oh, great.
Yeah, thank you. This has been really, really helpful and informative.
Great. I'm so glad. And, Arushi has my contact information, but of course, if any of you think of questions after the fact, or if you need help finding somebody, I mean, like I said, in New England, I think there's me, somebody who works part-time at MGH, and then somebody at Dartmouth who like really specializes in GI psychology. So it can be sometimes what I don't want it to be is frustrating to be coming to this talk and then saying I don't have access to that treatment. But so I would be happy to help any of you find somebody who like maybe isn't specifically trained in gastroenterology, but might seem like a good fit in terms of, having health psychology training. So anybody has questions like that, Arushi can put us in touch.
If you know anybody in the Tampa Bay area, that would certainly help. I'm from New England, but I'm not living there now, as you can see behind me. So.
Yeah. Although every year there's more of us because, there's specific training programs throughout the country that are putting out, more people. So I don't know if anybody off the top of my head, but I'll look to see. And if I can find somebody, I'll send it to Arushi.
Thank you.
I think this presentation has been very beneficial, and I want to thank you for that. I think that GI psychology is a term I wish I would have heard of in the beginning, because I will be the first to say that my emotions were not the best in the beginning. I was very negative and pessimistic and things of that nature. And I feel like that concept is so important especially for newly diagnosed patients to know that, they can get control of their emotions and it's not impossible. And I think that you've outlined that here diligently.
Yeah. Or even just to give yourself the space to be negative for a little while, but to know that it doesn't need to be permanent, and it's totally fine to sometimes I have patients that are diagnosed and I'll be seeing them very soon after their diagnosis and they're beating themselves up because they're I'm just having a pity party. And it's well, why wouldn't you have a pity party, right? Throw the party and then we're gonna help you pull it together.
Yeah, that's the thing I always say to people when it comes to the word pity. And I don't want to speak for all of us here, but what I will say is I speak for a lot of people that have Crohn's and colitis that say we don't want pity. That's the last thing we want, is for someone to feel sorry for us, because we don't feel sorry for ourselves because we can't do anything about our disease. We just have to figure out a way to live with it. Right. So that's what I wanted to convey there.
Yeah, exactly. But, I think going through all those emotions, or even getting to that point where you know what you need, that's such a, huge kind of process. And so having somebody that can even just give you some validation while you're going through that in the beginning is, I think, really important.
I just thought of something else too. There's an intellectual component in that some people, myself included, feel much better when I do all this research and I go online and I read books. I started years ago with Dr. Michael Gershon's book, The Second Brain, because he basically invented neurogastroenterology. But there are other people, and my dad was one of these, who didn't want to know anything about his medical condition. When he had whatever, prostate cancer and whatever it was he had, he's like, he didn't want to know anything about it. He didn't want to hear about it. It was like, and I think different people have different approaches. And I think for some people, all that information is too scary. It's too much. For other people, it's power. Knowledge is power. And doctors often will say, when you start saying, "Oh, I looked this up on the internet," they'll say, "Oh no," they're like, "Oh God," because there's a lot of junk out there, and it's not that easy to separate the wheat from the chaff. But I think that intellectual orientation is different with different people and different patients. And I think sometimes people who might benefit from some sort of psychotherapy and others just simply, wouldn't.
Yeah, I mean, I don't think so. I think there's many patients who don't need psychotherapy. I also think that, like, in my ideal world, like, every new patient in my clinic would be referred to see me for one visit, where I would just say, like, I exist and you might not need it, and if you don't need it, don't come, but like if you do need it, right? And so I think even that, like, little bit, like, that's therapeutic in itself. And even if it's completely clear that a patient does not need to meet with me, I think just knowing that that is available can be helpful. I also, the internet is like such a beautiful tool, and like there's actually a lot of really good information online and like really great support resources online, but it can become kind of like a way to fuel one's own depression and anxiety as well when you start to seek too much information, or you've kind of like past that point of it being helpful. I think finding that balance, I never tell a patient, don't Google things. Of course people are going to. Like, I wouldn't give advice that I wouldn't follow for myself, right? If you have questions about your health, where else are you going to go? You can't call your doctor every day. But I think, like, finding that balance and knowing, like, when you've reached that point that this is now not helping you anymore is a skill that we all need to, everybody needs to work on.
My wife has a term for it. She calls, if I'm spending way too much time, she calls it doom surfing.
Yeah, exactly. Once you get there, you got to turn it off. Exactly. But I think everybody, no matter what their health status, has fallen prey to that at some point.
And I talked with Arushi, and she just said that whenever it ends, we can just head off. There's nothing back in the main room.
Okay. Are there any final questions before we wrap up?
I did just think of one thing. I was curious about the medical hypnosis. Is that something that's really expensive or maybe covered by insurance in some cases?
So, yeah, so it's covered by insurance. Insurance says that they don't cover hypnosis, and so that's fine. So how I will usually do is, I'm never doing hypnosis by myself, like just hypnosis. Like, it's always in the context of some supportive counseling and behavioral therapy, and the actual, like, hypnosis time, I just don't bill for that, right? So you can get it covered. You can, like, so like if I see you for an hour, I'll bill for 45 minutes, for example. So hypnosis can be covered. I think it definitely should be covered by insurance, but at this point, it's possible to kind of like get the treatment without being, you don't have to pay for it out of pocket. It kind of falls within the umbrella of the behavioral therapy.
Okay, thank you.
I think too, there's a couple of research studies going on right now looking at, like, having access to virtual hypnosis. So, like, you wouldn't actually meet with a therapist at all. You would just get the hypnosis sessions remotely. And so it's more like, it would be more like a Calm app or like a Headspace app. And so if they show positive results, I think that could be an option in the not so distant future. All right, any last questions other than that? All right, well, thanks so much for coming to this breakout session. And if anybody thinks of questions afterwards, feel free to, I think, just be in touch with Arushi and she can forward them on to me. Okay.
Thank
Bye,
you.
everybody.
Bye. Thank you.
Thank you so much. Bye.
Thank you.